Welcome everyone to this IHPI seminar series. I'm Carolyn Richardson and I'm going to introduce Eve Kerr, and then Eve is going to introduce our panel for today. So this is a special IHPI seminar. It's sponsored by MPrOVE, which is the program for Value Enhancement, University of Michigan's program for Value Enhancement. And basically they're focusing on value in healthcare and research and policy. Eve Kerr is one of our faculty members here and a member of IHPI. She's a Lewis Newburgh Research Professor in Internal Medicine. She's also the director of the Ann Arbor VA Center for Clinical Management Research. And she is the director of MPrOVE. And she's invited some guest speakers here to sort of kick off the MPrOVE season. And I'll let her explain more about what MPrOVE is about. Eve has a long track record of health services research, and she's a leader nationally in improving quality, appropriateness, patient-centered care, and decreasing low-value care in health systems. And much of her work has been done in the VA, but MPrOVE is a new center that's trying to bring some of what we've learned in the VA and nationally around quality into the University of Michigan health system. So I'll let Eve take it away.
Great, thanks Caroline, and welcome everybody. We're very excited to be sponsoring with IHPI this seminar on healthcare value. And I'll just tell you a little bit about the Michigan Program on Value Enhancement, or MPrOVE. The goal of MPrOVE is really to tap into the expertise of IHPI members, all of you, and bring that expertise together with the needs of our health system, Michigan Medicine. So we're trying to bring together clinical leaders, research leaders, operational leaders, in order to identify, implement, and evaluate specific programs that are designed to enhance value at Michigan Medicine. And at the same time, we want to catalyze research on value in healthcare, and that research is intended also to influence and impact both local and national policy. When I say local, in the health system, the state, and then also national policy. So this initiative is about a year old. It's jointly sponsored by Michigan Medicine and the Quality Department specifically, and IHPI. And IHPI, of course, is focused on the research and the policy impact of this initiative. And so to that end, on September 27th, we sponsored our first Research Innovation Challenge. Some of you participated in that. We had about 50 faculty from across the university, not just Michigan Medicine, participate. And the goal was really to jumpstart teams, interdisciplinary teams, to work on kind of thorny, difficult problems in healthcare value, and then to motivate those teams to actually produce some proposals that can help tackle those challenges and lead to large-scale grant submissions. And so our speakers today, together with also Marianne Udow and David Miller here from Urology, Marianne Udow from CHART, heard 3 presentations from 3 top teams this morning. That was very exciting. And this afternoon we have the pleasure of hearing both Dr. Eric Schneider and Paul McCreadie speak about challenges in moving to high-value healthcare, and so we're looking forward to their perspective. So let me just tell you a little bit about our speakers today. So Dr. Eric Schneider is Senior Vice President for Policy and Research at the Commonwealth Fund. And the Commonwealth Fund is a national philanthropy engaged in independent research on health and social policy issues. Prior to joining Commonwealth, Eric led RAND's Boston office, and he held the RAND Distinguished Chair on Healthcare Quality. And prior to that, he was also faculty at Harvard, at the Harvard School of Public Health. And so he's really been an internationally recognized health services researcher focused on health policy, on quality measurement, quality system innovation. He's also held numerous national leadership roles and advisory roles related to healthcare quality, including for NCQA, ARC, Institute for Healthcare Improvement, American Medical Association, and the American College of Physicians, where he's also a fellow of the American College of Physicians. And Eric is also a general internist. He holds a BS in biology from Columbia University, an MSc from the University of California, Berkeley, and an MD from the University of California in San Francisco, which is also my alma mater. One of the things you won't find in his bio, but I'll tell you, is that Eric was actually born in Michigan. He was born in Lansing, and he grew up there part-time, and he went to Interlochen for high school. And we hear that some of his family members are supporters of that other state university, but we're trying to make him into a Wolverine, so please welcome him warmly when he speaks. Our second speaker today is Paul McCreadie. He's the managing director at Arboretum Ventures, and that's a venture capital firm here in Ann Arbor, specializing in the healthcare sector. And more specifically, Paul invests in capital-efficient medical technology service and health IT companies that are focused on innovation technologies in healthcare. So prior to joining Arboretum, Paul worked at Ford Motor Company for 8 years. He held a variety of management positions, product development and manufacturing and business strategy. And he was also an associate at Wolverine Venture Fund while he was an M.B.A. student at Michigan's Ross School of Business. He also holds multiple advisory positions for healthcare and entrepreneurial companies, including for University of Michigan Cellulary Commercialization Fund. And for us here, he's on the National Advisory Board for IHPI. So Paul earned both a BS and an MS in mechanical engineering here at the University of Michigan, and then, as I said, an MBA from the Ross Business School here at U of M. So we're very excited to have these two speakers talk to us from different perspectives about healthcare value, and to have a little bit of the time also for your questions and some lively discussion. I will remind you there's a reception at the end, so feel free also to mingle and ask questions at that time, any questions we don't get in. So our first speaker today will be Dr. Eric Schneider, and I think we have your slides here.
Well, thank you, Eve. That was a very kind introduction. It's really a pleasure to be back in my home state. I haven't spent a lot of time here over the last many years, and my brother was a doctoral graduate from Michigan State University. But I have never been there aside from being born on that campus. So hear me out. What I want to talk about today is bringing together a couple of streams of past work that I've been engaged in, and this is a great opportunity. I'm going to do in 20 minutes sort of an overview of a couple of these streams of work. From the perspective of a researcher and also now from the Commonwealth Fund perspective around policy on this issue of advancing research to reduce low-value care. Because I think there's been considerable progress. What I'll do in the 20 minutes is talk a little bit about the value challenge. I'm going to run through that fairly quickly. And then I'm going to move to thinking about the question, how can better value in healthcare actually be achieved? And then offer some thoughts about the future research on value. I'm going to skim over some things, but I would be very glad to come back to them during the Q&A, depending on your interest. So the first question that comes up in this area, which has come up since the inception of the work about value, is how to define value. And it's early on, it's really been the good and the bad. The traditional clinical model, which I don't think has ever been described per se, but I would call it services a doctor believes could benefit a patient. That was the definition of value in the 1960s. It's actually sort of reflected in Medicare policy, actually, because the legislation that created Medicare said that Medicare would not work to influence or interfere in the practice of medicine. And so that notion is a bit deeply rooted in healthcare in the US. And then in the 1980s, the appropriateness model was developed by researchers at Rand Corporation. I have worked in the appropriateness area for a while, but I did not realize that the Commonwealth Fund actually supported the early work on the development of this methodology. There's a report that I noticed the Commonwealth Fund logo under, so I went back and looked, and in fact, in the early days when no one else was interested, the fund supported this work, which then went on to be used in the famous study of the effect of DRGs and hospital payment on hospital quality. But the appropriateness model really was sort of the gold standard. I think to some extent still is the gold standard. And the idea is that here we're going to rationalize or standardize the approach to this services a doctor believes provide value. And so the definition is for clinical indications, those services for which scientific evidence and clinical expert opinion determines that the benefits exceed the risks. I think that's a really useful conceptual definition. It actually got operationalized in a way that's made several studies possible, although they're very expensive to do, and really is the origin of what we know about the rates of appropriate procedure use in the US and in other countries. Around the same time, there was a model that evolved around patient preferences. That the patient preference model says that valuable services are services a patient chooses to receive after being adequately informed of the alternatives. So you can see already there's that one has a bit more of a patient orientation, an autonomy of patient decision-making orientation, but it still has to be grounded in some sense of, well, how would you inform the patient? What's the evidence supporting the effectiveness of these services? The most notable thing about all three of these definitions, though, is that none of them includes the issue of costs or spending. That's actually not a consideration in thinking about appropriateness, at least in these models. So I'm going to, sort of asking the question about what's the value challenge in the US, I'm going to turn to a report we released this July. This is actually one that we've been publishing for several years. It's gotten a little bit revamped, which is an international comparison where we looked at 11 high-income countries and we assessed the performance of those countries on standard measures developed from surveys and from other data sources. And we published a companion piece with it, which may be of interest in the New England Journal, September, asking the question, how could the US move from last to first? But you didn't know that the US was last yet, so I'll show you that. We are first in spending, so this is the spending graph. And you can see we're at, this is 16.6% of GDP. We've been on a faster growth curve in spending than any other country. We spend more per person than any other country in the world on healthcare. But the problem is what we get for that is an 11th place showing. That's the US down here on the lower right-hand corner. And I've shown this is sort of the standard deviation of aggregate performance. Again, not including costs here. This is just access to care, care process, administrative complexity, health outcomes amenable to health care, and equity. And France and Canada are sort of close seconds to us. The top performers are the UK, Australia, and the Netherlands. So putting those two slides together, we can say in an international context that the US provides low-value healthcare just based on performance, but the cost part also suggests that value is not optimal. That's a big problem. This is another report we've just recently published. This is the percent of adults aged 19 to 64 who are underinsured, meaning they're spending more than 10% of their income, or 5% if they're low income, on out-of-pocket costs because their insurance doesn't get them far enough. So that's 28% now. 1 out of 4 US adults is in that situation. Doesn't sound like a high-value proposition if you're in that group. So that's a growing problem. This goes back to 2003 in our tracking studies. And then we're seeing a similar problem emerging in Medicare. The green line here is projected Medicare spending during the next 10 years. because of the demographic aging phenomenon, spending is set to double over that time frame, according to MedPAC. For fun, I put up the projected net deficit spending of the U.S. government. So you can see it's actually roughly similar to net spending on Medicare. And the blue line was the projected deficit before the currently proposed tax bill. The orange line is the deficits after the tax bill passes, if it passes. And that tells you where our deficit spending is going to exceed Medicare spending over the next 10 years. And those two are related, of course, but we won't get into that now. The other challenge here is that overuse is costing a lot of money. So the early studies of overuse suggested the range is anywhere from 10 to 30%, depending on the procedure one looks at. This is some information around that was published by Carrie Kalla and her colleagues around 11 procedures that where they're called Choosing Wisely services. People may be familiar with that. It's professionals defining services that should rarely be used. That's a fairly strict and narrow definition of overuse, but it racks up a lot of money. If you look at the mean amount of unnecessary service, the interquartile range here across all the local areas of the country, and the estimates of spending on those services for people who probably won't benefit from them. And the combination now of thinking around the appropriateness or quality of care with the cost of care has really come into the fore. So the new model that was proposed by Michael Porter in the New England Journal in 2009 is what I call the health outcomes cost model. So it's the simple definition of the health outcomes achieved per dollar spent. And that model now it actually sort of leaves the health system performance aside and just says, how much health production do we get for every dollar we spend? The numerator is supposed to measure condition-specific multidimensional health outcomes. That's actually not a trivial task. The denominator is an aggregate spending for a cycle of care for a condition. That's also not trivial to define. It requires the ability to measure health outcomes and spending over time, not trivial. And you're supposed to define this for patient groups who have similar needs, but we know that's also very hard to measure. As I said, it's agnostic to what the process of care was that produced those health outcomes. And nowhere in that definition is there a sense of who's accountable for the spending and the health outcomes. This could be very useful on a population basis at a nation or state level. Less clear how to use this in an organizational context, although that's Porter's intent for sure. So we've now got the good, the bad, and the costly. And the question is, what do we know about achieving better value in healthcare? I'm going to not talk about financial incentives. I think that Paul is going to get into that. But I want to focus instead on what we know about directly changing care delivery to improve quality of care and improve the value of care. So the fundamental need here is to change the practice decisions of professionals, staff, and organizational managers. We have a delivery system reform program. That's really what our program is about. In a very brief summary, I'm going to say the interventions that have been shown to be effective in that context are improvement collaboratives, campaigns, the cyclical process improvement, the CQI or PDSA approach to incremental improvement, and clinical decision support at the point of care delivery. I'll posit those as the three most effective ways of achieving this change. There are a ton of challenges associated with even these successful interventions, and I'll show you in a moment a longer list. The challenges are that these, by and large, produce incremental and very modest changes to quality and to spending. They usually focus on increasing the use of evidence-based practices. There's actually been very little work on reducing or de-implementing low-value care. they are difficult to spread and scale. So when one does a pilot like this or uses any of these methods in an organizational context, you see it work in one place. It's rare that it actually then gets spread and scaled elsewhere. And there is tremendous resistance to change in general, limited sustainability of these interventions because of the environment, organization, and social dynamics, and individual habit. This is a summary of what's known about specifically the published interventions to reduce low-value care. I think this ends up being about 80-some articles that, again, Kerry Kalla's group published on. And they reviewed all the known interventions, all the published literature on those interventions, and again point to clinical decision support, clinical education, and multi-component interventions as the most effective ways to achieve, where there's the best evidence that change can be achieved. The other studies here, the other interventions, there's just less known on average. I mean, many of these are just one study in the published literature that was rigorous enough to know anything, and the effectiveness is sort of questionable. So a paucity of research. This is a research opportunity for those who want to continue to pursue how to make these interventions work well, and also how to combine them with one another. This is an example of clinical decision support, well-designed clinical decision support implemented. This was published in JAMA in 2016, and then a follow-up here 2017, that well-designed nudges designed into an electronic health record system, in this case, peer comparison at the time a drug is being ordered, showing people where they line up relative to their peers, turned out to be very effective at reducing the inappropriate prescribing of antibiotics. You can't see it, I can't see it well, but there's an intervention period and then the intervention's taken away. And you can see this lower yellow line here that the intervention is sustained after that point. They actually tested this against two other approaches. One which was an administrative control, and I can't remember the other one, but only this peer comparison one was effective in a sustained way. So I would commend you to this as probably one of the best done studies on reducing ineffective care using clinical decision support with a behavioral nudge. Why doesn't this work? Oh, the other thing that's interesting about this graph is the steady decline that's already occurring. That's actually the most striking thing here, is there's already a decline in the inappropriate prescribing rate. Now there have been several campaigns underway for a long time to change this practice, so that's probably accounting for part of the decline, but we don't really know often why things change. We are left trying to explain them. This slide, the point is just to point out that there are several reasons why people don't comply with these types of interventions. And they are often external issues, concerns about malpractice, wanting to keep patients happy, not enough time for meaningful decision, fee-for-service payment that's rewarding bad behavior, I guess. So there are a variety of reasons why people don't respond to these interventions, and that always brings me back to this conceptual diagram that I use when I'm teaching quality improvement, which is that the poor clinician at the sharp end of care is in many ways a victim of everything that's going on above in terms of group dynamics, institution and organizational policies, payment system and regulatory demands. And we haven't even put the poor patient here at the other end of this, but there is it's very hard to change practices without influencing all of these levels of care. Now what I want to pivot to now is though the question about whether industries could potentially teach healthcare about achieving higher value. Because in other industries the value, the transformation of value can become quite apparent, and the cost of things tends to fall, and services become available that we never had before. So how do they achieve that? And I'm going to turn to the work of Clay Christensen, who has really, I think, and others who've in the management literature have helped us think about how these transformational changes occur. This is a schematic we created to help us understand the relationship of various forms of change. So in the core area is the idea that we take the current existing set of practices, structures, and we try to optimize it. This is actually a classic continuous quality improvement model. We do small incremental process and service improvement, and we mostly use the existing clinicians and stakeholders in that process. Adjacent to that is something a little more aggressive, where we're bringing in a different person or staff and a potentially stakeholder, and then we're bringing in some new ways of doing the process. So in my own clinical practice, it was when we started managing diabetes with a diabetes educator and manager, and we're no longer trying to rely on clinicians to do the teaching. I would call that an adjacent activity, but we're still operating in our current delivery and payment system. Transformational change really occurs in a different way. It involves radically new services, radically new processes, very different people and stakeholders. And the disruption happens by combining three key elements. One is a technology enabler that wasn't there before. This is what happens in other industries. In this case, for healthcare, we are in the precipice of cellular data, internet, digital sensors, secure messaging platforms, tools, platforms that didn't exist. So those are the technology enablers. You couple that with an innovative business model. In this case, you could think of intensive home-based care for high-need, high-cost patients. Iora, ChenMed, Landmark, and CareMore are companies that are actually doing this now. They're actually targeting resources in a home-based way to high-cost patients. And then the third necessary element to disrupt the existing value equation or process is this economically coherent value network. And one of the reasons there's innovation around CareMore, ChenMed, and Iora is because Medicare Advantage is creating risk-sharing contracts, and health insurers are actually creating risk-sharing contracts with those companies. They do a lot of coordination with primary care, emergency room, and hospital that isn't done by any of those entities separately. So given this technology enabler, a vision for how this process would play out, and a network, the opportunity to use an economically coherent value network, one can get innovation. And where we've seen this the most is in the digital technology space. We now do mobile banking. We can real estate, retail, online. This is an app over here that allows you to plan for a vacation. It'll tell you what to put in your suitcase. Once robotics get far enough advanced, they'll actually pack it for you. This is level of convenience that no one really could have anticipated even 10 years ago. And what we've done at the fund was to describe what we think this sort of future consumer-oriented, value-driven system could look like if we could get there. And we call it the digital health advisor. Pete Zolovitz called it the guardian angel when he first developed this in the 1990s. The idea is that there is a platform, it says app here, but I think really it's a platform of digital services that would interact with a person in real time, much of it algorithmically driven, that would be drawing data from multiple sources to provide care. If you want to read more about that, it's on our website, Envisioning a Digital Health Advisor. And we've used this vision to think about how the transformation paths will occur to get there. So I like to use this example. The path to value is not always easy to discern. Some of you remember bank tellers, going to stand in line at a bank with a bank teller. That was a really high value experience back in the day. And in 1961, the bankograph was introduced. This was an automated teller notion or concept. And in 1969, the Yes machine was introduced by Chemical Bank. And there were no ATMs in 1978 when I moved to New York. That was not a thing, really. But then it turned out that Citibank had actually deployed ATMs. No one was using them, but they were sitting around the city, and a blizzard happened. They thought this is the future of banking, but no one would use these machines. But once there was a blizzard, People couldn't go to the bank and get money. The cash machines were running out. The city was paralyzed for days. And next thing you know, people are saying, well, there's this machine. I can get cash out of it. And it worked. So why was there all that resistance? It was actually an interesting story. There was mistrust of, would the machine actually give you the money? Would it count the money correctly? How did you know you weren't getting scammed? But once people had used these machines during a blizzard, that sort of broke through. And ultimately, shared networking model emerged that enables all of the financial transactions we do today. So this is a huge value increase for the average customer. I'm going to go quickly here about my thoughts about the future of research on value, and happy to take more questions after we're done talking or after Paul's done talking. I think there are several opportunities in the research agenda around this, the development, testing, and evaluation. But I think we should think about these two different streams of work. One is the incremental improvement of our existing processes, developing and testing the novel tools that we can put into the process and implement in care delivery to increase value. That's work that's going on, and I know I heard several examples of it today. We need to do more in that area. But the second is to describe and evaluate these potentially disruptive platforms and business models that are not currently part of the incumbent healthcare system. So it's going to be outside of the delivery system where some of this development is going to occur. Being prepared to study the impact of those novel innovations, value-enhancing innovations on populations, I think is going to be a really important part of the agenda. These slides will be available. There's a set of measures. We've been thinking through kind of what all the measurement opportunities are. You'll see that we've sort of nested these. The measures on the right side are the really critical ones. Understanding how people experience and their health outcomes and other important dimensions of their life turns out to be really important if you really want to understand how value is created. Then there's the clinical side on sort of more standard quality measures. There are workflow issues that are often not attended to. And then there are technology issues. And because these are technology enabled, that's really important to capture those. There are also a long list of methodologies, well, this is a short list of methodologies that people should be thinking about as future research methodologies if they're not already doing that. One is human-centered design. This is actually really revolutionizing the way that the development of these tools happens. A second is network analysis and social network analysis in particular. There's much greater understanding now of how practice change can occur across networks. Measure development and validation will be important. Data science to address the big data sets that are being created through all of the digital activities that are going on around us. And then machine learning, which is an interesting area to maybe come back to. I'll close by just re-emphasizing this point about the two roads to high value and thinking about research in these two roads. The first is decision-modifying interventions that we're going to implement to get clinicians to provide more care more precisely. And the second is the study of these new disruptive business models built around in technology enablers and the new payment incentives that I hope we'll talk about. And then finally, it's really critical to go beyond the Porter model, I think, to not just focus on health outcomes produced for a dollar unit, but to actually tie that to the business model, because it's the business model that will actually deliver, and the costs will be tied to what that business model is and how it's arranged and organized. So without that information and information about the costs of implementation, it's really going to be difficult to understand whether we're improving value or reducing it. So I'll stop there and turn it over to Paul.
Well, thank you for the invitation to be here. And as Eve mentioned, we were here this morning listening to some very exciting proposals as a part of the MPrOVE initiative. And I have to say, for me, I always learn a lot when I'm at these events, and I learned quite a bit about grants and the whole process for getting funding for a lot of the research that's done here. So That was a really interesting morning for me. So I'm going to continue on Eric's topic here, and some of the points he made actually are very relevant as he was wrapping up with regard to how we look at value and opportunities in healthcare where we make investments. And Eve gave you most of my background, so I won't spend much time on this, but I've been with Arboretum Ventures for about 12 years. I joined our firm at sort of the tail end of one of our first funds, and we have now raised 4 investment funds over the last 15 years. My 2 partners that started Arboretum got together back in 2003. I have, as we all do, responsibilities for specific portfolio companies of ours in which we've made investments. I'm sort of a generalist, so I've done things both on the Medtech side, healthcare services, and health IT, which all have relevance here. And as I mentioned, our firm was formed back in 2002, and when I have only 10 seconds to explain to somebody what we do, it's very easy to say that we'll invest in any area of healthcare that's really not biopharma, specifically medical technologies, healthcare IT, and tech-enabled services is where we like to focus, with a real emphasis placed on capital efficiency and, of course, reducing costs and driving value. So, and just for some context about what venture capital is, I know this is certainly not the emphasis of this conversation, but to give you a little context, we invest money from investors that we are raising funds from because really they want access to private companies and high growth opportunities in these startups. So a lot of the foundations and institutions that entrust their capital into our hands are doing that because we've got the networks and the expertise to find those opportunities. So we do this by bridging the gap between that capital and entrepreneurs, and that's really what we get paid to do, is find really exciting opportunities, provide capital, those resources, experience, guidance along the way. We create a portfolio of investments in each of our funds, and that usually is somewhere between 12 and 15 companies. We'll invest that money over about a 5-year period, and it takes a lot longer than that, longer than we'd like, to sometimes get that money back out. I say here that our investment holding period is generally between about 5 and 8 years, but there are certainly some exceptions that exceed that, the larger end of that range. And what is a successful investment for us means that we've invested our capital in the company, they've been successful, oftentimes they're acquired by a larger strategic company, and then the returns are what we are able to deliver back to our investors. So just to begin with a quick example of successful innovation, I chose this example because, one, it's an Ann Arbor-based company, was an Ann Arbor-based company, and secondly, it came from technology that was licensed outside of University of Michigan. And this is a molecular diagnostics company that's called Handi Lab. Handi Lab, as I said, it was spun out from U of M, was really founded by 2 postdocs that were doing research here at U of M back in 1998. Originally, it was focused as a point-of-care diagnostic, but ultimately, when you play this forward 10 to 12 years later, and after about $55 million in funding, was actually acquired for a different application altogether because the initial point-of-care diagnostic was not successful. And Becton Dickinson acquired this automated kind of high-throughput molecular diagnostics platform and closed on that in 2009. The road to the end is never really straight. And this is a timeline. I won't go through all the details here, but over these 10 years, and the funding at the bottom here shows you where, in the red, the equity capital was raised. There were some other grants that were raised. But this took $50 to $60 million in about 10 years to get there. There was about a 3 to 4 year period of a lot of core development. This point of care product, as I said, didn't really deliver on the promise of having this lab on a chip. And so there was a pivot, which is the term often used now, to develop this high throughput platform in the 2007, 2008 timeframe. And that's when the company was acquired. So it was a very significant success for the founders, for the employees, and for the investors. And that just gives you a sense of innovation is not easy and oftentimes takes a lot of capital and time. So Eve asked me to focus a little bit on what excites our team. What are the kinds of things that we see and themes that we invest in that really relate to value. And my first point here is that the focus is clearly on value now more than ever. I would suggest that many investors like Arboretum have been trying to find these opportunities even before it was well known, and there's a lot of emphasis around it. But the lens that we look at things now has everything to do with cost effectiveness and ROI, or return on investment. What is a health system or a payer going to get for investing in this product or service? Because a lot of Eric's data that show how we rank in terms of our value, our spending, we're clearly not getting it done, and there's a lot of opportunity. So we think that health systems, despite the fact that now there are a lot of programs which incentivize value, are ill-equipped to really deal with that. And I say that from a simplistically, even defining value, measuring value is one of the most significant challenges. And so it's nice now that there are some structural changes that have happened with a lot of the ways we pay for care delivery that are incentivizing this, which have really been have been tailwinds for a lot of companies that are operating in these areas. The role of the patient. So now, if you look at information about the prevalence of high deductible plans and the share of that is now in the employee or the patient's hands, is very significant. I think for the first time ever, people are now really paying attention to, do I want to pay for this procedure? Where will I go for care? I'm responsible for a significant part of this deductible. Is it worth it to me? I remember back, Eve mentioned that I came from Ford, and I think in the 8 years I was there, every single year, our insurance coverage got a little bit worse and a little bit more expensive. But I remember even in the early days, you didn't even think about it. You'd show up at the doctor, you'd present your card, and whatever they said you needed to do, you'd go and have done. So understanding the patient perspective in this is very, very significant. This next point is rather obvious, but these large market opportunities for chronic disease, that really have significant prevalence and incidence, often fueled by the aging baby boomers, are bringing a huge cost burden to Medicare. So, they're obvious ones, but diabetes and how the obesity epidemic is affecting that. Other aspects like heart disease. There's a lot of technology, both in the way that we interact with patients, not just even devices, but interactions with patients, population health tools, trying to keep people healthy and out of the hospital is where we need to really spend our time. Technologies that enable care delivery in lower acuity settings. A model that's proven very effective is taking a rather invasive procedure and using technology to find a way to make that much less invasive, where rather than a hospitalization, that could be done in an outpatient setting or an ambulatory center. We have a number of companies that are kind of working on that model where you can prove equivalent outcomes, but if you can even just match outcomes in a different care setting, the value equation tips very favorably in your direction, just because of the reduction in cost of having inpatient care delivered. So we always kind of use this mantra of faster, better, cheaper, and that also means that clinical adoption is generally much easier, because these new technologies, new treatments don't require a lot of training, and really you've got to think very carefully about how the physician perceives these, because he or she ultimately is going to be the one that allows some of these new treatments to be successful or not. Moving on, so reducing healthcare administrative burdens. I mean, this is something that we hear a lot about, and there are a lot of companies in the health IT space looking to address. I think anybody here who practices medicine would have a thing or two to say about the role of electronic health records and what that has or has not done for patient care. Every single study that I've ever read or seen certainly does not support the fact that better care is the result. I mean, that was supposed to be the goal, but what's ended up happening is a lot of these disparate information systems have created a tremendous amount of headaches and a huge burden, even just to manage EHRs as an example. So now in order to access, for the doctor to access patients, a lot of digital technologies, mobile technologies are being used to engage with patients. So rather than requiring them to come into the clinic? Are you able to communicate with them and deliver information in a way that keeps them healthy and doesn't require them to come in for a visit? So those aspects really are going to help address some of the administrative burdens, because the path we're on is unsustainable, and there's a lot of improvement that's going to be necessary there. Next, consumer health. So this is an area that is really grown into favor with venture capitalists. And the big reason for it is because the consumers are the ones making the decisions and writing the checks. Something that I'll talk a little bit more about later is just reimbursement risk. That is probably the largest risk that a lot of the companies that we invest in and look at are facing. Years ago, there was a lot of uncertainty around the FDA. I think the FDA has done a terrific job in reconciling that process, making it more transparent. Reimbursement is incredibly opaque, very lengthy, and very hard to figure out. So technologies where you're bypassing that and it's a patient pay or private pay model are very attractive. So consumer medtech is a big area of focus. And as I said, it really eliminates that third-party reimbursement risk. And from our perspective, that's one of the biggest challenges, because it's a lot of times not necessarily if we get coverage or code, it's when. And we've got to fund these companies that are burning cash, and they've got, the more months they've got to wait for these types of decisions, the more capital they consume. So really, visibility and transparency on that is significantly important to a successful, startup ecosystem. And mental and behavioral health is another, certainly a very significant public health crisis. Access to these specialists is limited. We have a couple of companies that have made advancements in this area where, it's more about, leveraging a scarce resource. For example, we have a company that's based in New York that's focused on children with autism. With coverage mandates for autism care and coverage, that just meant that in many states, it's not all 50, but it's a vast majority, that there's a lot of families that are now into a covered benefit scenario where there's just not enough people, there's not enough therapists, there's not enough treatment options for them, and so the waits can be very excessive. So telemedicine technologies, mobile platforms, this is an area just providing access, whether it's maintenance or in crisis type situations, is going to be very important for advancing behavioral health. And we talked a little bit about this morning in one of the groups that was presenting about mobile health and telemedicine. So this one, I'm sure there's a lot of people that would certainly not disagree with that comment about addressing physician shortages, staffing, and just physician satisfaction. The whole goal of, the triple aim of providing, better care at lower cost and increased satisfaction, quite honestly, in many areas, in particular primary care, I think is going to be very difficult, if not impossible, to achieve without making some changes to how physicians' work-life balance is. I mean, we're constantly looking for ways to put more on the shoulders of the primary care doc, who's got whatever it is, 6 minutes per visit, and they've got an EHR to fill out, and they've got a scribe or somebody in the room with them because they don't have enough time to do this. And so we really do need to emphasize, again, technologies that will reduce those administrative burdens, as I talked about before. Elder care, healthy aging, kind of aging at home. I just returned from a conference a couple weeks ago that was called Aging 2.0 that's out in California that talks a lot about how keeping folks out of the hospital and allow them to age at home and really meet their own wishes and desires is an area of a tremendous amount of innovation, and these are oftentimes telemedicine or health IT oriented technologies. I know we're kind of coming short on time here, Eve, aren't we? But so just to summarize a few of these things, from our perspective, this transition of fee-for-service to value is a huge positive impact for the community of investors that are looking at startup companies. It really has provided the incentives to drive these innovations. There's a good geographic dispersion around many very well-known research centers that are driving innovation and a source of a lot of intellectual property for a lot of these. So that's certainly a very positive impact. We talked about third-party reimbursement. That's a huge negative force that I think really has to be addressed, or else this is going to have a significant stifling effect on innovation. And I think it's a mixed bag where you look at whether patients' contribution to their healthcare decisions are positive or negative, from the standpoint of are companies equipped to market and approach them, but on the other hand, you get around the issues that I mentioned before of reimbursement. So maybe I'll hold on this because I think one of the topics we're going to cover maybe in some of the Q&A are just kind of translating research into impact. And some of the things that I've talked about with John and the IHPI group relates to corporate partnerships and sponsored research and how the relevance of your research can be made even better. The researchers here offer independence and a lot of credibility, and a lot of companies don't have the resources or the means to do that themselves. So thinking about ways in which you can, as I say here, kind of begin with the end in mind, and whether it's outcome measures or other aspects of your research that could be not significantly changed, but make it much more relevant to a company, to a strategic company that's in this field that could really benefit from the work that's being done here. So I did say again, and I'll just emphasize it: the payment and reimbursement risk is a considerable area of risk for many early companies, and to whatever extent that could be a subject that's kind of investigated here or done some research on how that uncertainty is affecting innovation, I think would be some important work. So I'll stop there, and I think Eric's going to come up and we're going to take some questions. So thank you.
Well, we do have some time for questions. This is on. And we have, so actually we'll take questions from the audience first. I have some questions too, but I want to hear what you all have to say. Stacy has a microphone, so this is being audio taped. So if you have a question, if you could raise your hand. But if you don't, I'll ask the question. All right, so I'm actually going to stay on that theme that you started, Paul, because I'm going to give Eric an opportunity to comment on it as well. So this issue about impact is a really big issue for IHPI, and it's something that we think about all the time. How can we make sure that the research that we're doing is actually translated to policy, and it's translated to changes in practice, and it's potentially either fuels innovation or, when we haven't thought as much about translating it to kind of industry. And you talked a little bit about that, Paul, from your perspective, how we could do that as researchers. I'm going to give Eric a little bit of a chance to comment on that as well before we go on to some other topics.
Yeah, so thanks, Eve, and thanks, Paul. That was really terrific. So there are a couple of different ways that this is going to happen. One of the interesting challenges of the U.S. system is that about half the revenue comes through public sources and half comes through private sources, private employer insurance and out-of-pocket costs. And it's because federal spending is federal and state spending is such a big part of the healthcare bill. I do think research that supports payment reform is actually really important in order to make the case or continue to make the case for the Centers for Medicare and Medicaid Innovation and the value-based payment reforms that they're proposing. So I think continuing, or if there is research going on, doing that is going to be really important. I think Paul really touched on an important kind of evolution of research. The traditional research model was very much sort of federally funded research. I think going forward, it's going to look more like the biotech and pharmaceutical industry, where it's actually partnerships with companies are going to be really important, and providing the research capabilities that those companies need to advance their agenda is something to be thinking about, even if you're in an academic setting. And actually the pathway for this is well worked out in pharmaceutical and biotechnology. It's not to say there aren't issues or challenges, but universities are really have been adapting to this kind of evolving research environment.
Great. Anything to add beyond?
Well, I shared, I guess, my comments when we were wrapping up, but I think, my observation with a lot of the work and the projects that I learn about here is that, the answers to the questions that you're developing within IHPI, I think have got a lot of relevance. And I just even think about some of our own companies. What's a means to get in front of them or bring some of these companies into the conversation? Because, even small tweaks in, as I said before, measures or outcomes, or what kind of data presentation are you going to create with your research would have a lot of relevance. And so maybe it's just a discussion about maybe having that input brought in some way. And ultimately, it could be a source of funding, clearly.
So you both talked about the patient in your presentations and kind of value. And a lot of what we've been thinking about, a lot of what you talked about is, how do you make healthcare work for the patient, right? It's that the model where the patient's at the center. It may be that the patient now doesn't have to wait as long. The patient actually, it's kind of like your ATM machine. The patient can pull from the system. Maybe it's through virtual means that they can now see a provider. Potentially that accrues some benefit to the health system, but a lot of that benefit may accrue to the patient, right? The benefit may be that it's actually saving the patient time. And I don't know whether that is actually captured in that Porter equation. I don't know whether the health system actually says, well, that's really beneficial to me. How do you both think about that from that perspective? If the value accrues to the patient, how do we capture it and make sure that that is something that is seen as important?
Maybe I'll start it. I think that's a very good way to pose the question, because one of the things that's interesting is when you think about who's paying for something and who benefits. So a lot of the technologies that make scheduling easier, or virtual visits, or other things that would make it more convenient for the patient, because they clearly want convenience. They certainly want good health care, but they really want convenience. Well, who pays for that? The patient oftentimes is not. I mean, certainly there's concierge medicine companies that, are charging a very small percent of, or addressing a very small percent of the population in charging for that. But speaking more broadly, it's all about finding the evidence and the measures to show that these technologies, like as we said, virtual visits or telemedicine or other means to engage with patients on a mobile platform, do those actually deliver on providing better health or at lower cost? So, that kind of research is going to be important, because there's a lot of reluctance for payers, for example, to adopt these kinds of technologies for their beneficiaries, because there's not a lot of proof yet that they yield results. The patients certainly would like them for convenience, but that's not always the first criteria that they might use to make those decisions.
Great. So Eric, if you could answer, and then we do have one question.
Yeah, I would just add that the measure development part of this is really crucial. In the early days of IT development and other industries, there was a recognition that the measures of value and productivity were absent. And so companies actually had a very hard time telling whether they were improving value by implementing digital innovations. Because of the problem of the lack of competition in our healthcare system generally, we can't think of the banking model as the right analogy, because there aren't competing firms that can draw away the customers. In some markets there are, but it's relatively rare. And also healthcare is sticky in a way that people want to tend to stay with their providers. So I think being able to measure that in a way that decision makers, payers, can actually recognize what's higher value and move people to it is going to be critical.
Right. So Amy has the microphone. So I'm going to take a question from Amy and Joel, and then we will wrap up from there. So Amy first.
Thank you, Eve. So one of the things that I'm hearing resonate throughout your talk and beyond
Can you
this.
maybe introduce yourself first?
Oh, sorry. I'm Amy Cohn from Industrial Engineering in the Center for Healthcare Engineering and Patient Safety. And part of what I've been hearing is the role of the patient. And I think there's there's something very important and exciting about thinking about patients making decisions, whether it's the value and as they have higher deductible premiums, making decisions about their care. When we think about customized and customized medicine and precision health and patients making decisions about their own values, the thing that worries me sometimes with that is that all implies a fairly sophisticated patient. And when we think about online scheduling, that means you have computer access, which is not the case for all of the patients that we're seeing. And so I'm just wondering if you have thoughts both about your level of comfort or optimism, but also about the potential research and technology opportunities for how do we make sure that we are in fact educating across the spectrum at the level that patients truly can be educated consumers, even if they're not necessarily very well educated in the broadest sense.
I mean, I'll just briefly comment that the early phase of this sort of evolution is typically at the high end of a market, and then it gets democratized down. So I think it's really important to be paying attention to that, but I also think we're in for a sort of, cell phones used to be only for the wealthy. Now they're ubiquitous. I think we would have to think about it in those terms. But I also think that we're not yet at the point where we appreciate how much computing capabilities will enable people to have for it to be simple for them to do things that are now currently complicated. I always think of diabetes as the example where patients actually were using glucose monitors much more effectively once the technology got to a certain point. Even my low-income, uneducated patients could do that. And so it's really about the design.
It's a very fair point. I think it's easy to speak about those things in a vacuum, assuming that everyone has that level of access. But I think, as an example, a lot of Medicare, Medicaid eligible patients. We've got a company that addresses the dual eligible population. There's a huge need there, and bringing those folks in more easily to the health system is simply it's just getting access to them, finding them. So it's not always a huge technology solution, but I think it's also designing the primary care facilities and operations around their needs as much as it is some of the more technology-oriented aspects that you very appropriately point out, that we can't assume that everyone has the new iPhone and can do a televisit with their physician. But oftentimes, I think those folks avoid the healthcare system because it's not designed for them and it doesn't work for them.
All right, I recognize we're just a few minutes over, but we're going to take one last question from Dr. Howell, and then we will conclude.
Okay, I'll be brief. Just a brief historical observation and question. The observation is this ain't new. The technology changing the fundamental interactions and structure of healthcare. Imagine, for example, the difference it made with the invention of the telephone. Before there's a telephone. If you wanted to find your doctor, you needed to go into town, go to the office. You had no idea if she or he was there. The invention of the automobile that allowed people to move around, including physicians. So JAMA actually had papers about if you were a doctor, should you buy a car, and if so, what kind? The point being that this notion of technology disrupting and overturning the fundamental verities of healthcare, yes, you're absolutely right, it's going on, but it's been going on for at least a century with changes. If I had more time, we could talk more about it. I mean, the fundamental structure, the invention of the memo, the invention of the spreadsheet, the invention of cost accounting. All of these things had to be invented. They were all invented in the early 20th century. They all had profound implications, just as what's happening now is having profound implications. That's the observation. The question, this is for Eric, although Paul's welcome to chime in as well. You used the term unsustainable. Okay, that term has been used when we were spending 10% of our GDP on healthcare. I mean, I've read documents from people just tearing their hair out. This is 10%, we can't possibly go on. The whole damn thing is gonna crumble. This has to change. I don't know how it's gonna change, but 10% is just totally unsustainable. Now we're at 19, does it change? When does the whole thing finally crumble, or do we?
They're a tipping point.
Well, I think we're already past the tipping point for a lot of populations in the U.S. And I also think that I don't want to get into politics in this conversation, but the political discussions we're having around spending are not new, obviously, but there's a recognition when you say 1 out of 4 people are underinsured, and they start wondering, well, why bother having insurance? And you say, I can't really afford to go to the doctor, or it's inconvenient, or it's across town, it's a big thing, don't want to be in there. And then you look at our health outcomes in the US and the trends, including some groups for which there's increasing mortality. I do think at some point that isn't so much about unsustainable spending, but about kind of social choices that will come through a political process. Whether we want to go through a revolution of some kind to get there, I don't know, but that's all I can offer. I agree with your point, though, that these innovations are not new. There is a dynamic around combinations of innovations that produce something that's possible that wasn't possible, and that's sort of what I think healthcare is looking for, but we also have a lot of barriers to that.
Your point is certainly well made about technology innovations have happened in the past, but the one thing I feel is different now is that structurally, the way that we're fundamentally paying for care is changing and changing fairly rapidly, and that's that's the catalyst for why this change is necessary. It's not technology for technology's sake, it's a means to accomplish these goals, and if we've reconciled, a lot of the unnecessary, the more volume, the more payment kinds of notions in healthcare, which are happening, I think that's why it's different this time around.
Well, I want to thank both of our speakers for an excellent presentation. Please join us for a reception outside, and I'm sure they'll be happy to take more questions as well and meet many of you.